So, without further ado, to my left, Dr. Kev Smith. Can you introduce yourself, Kev, and then briefly say what you feel your role is for your organisation in the AMR agenda?
Yes, okay. So, morning everyone, I'm Kev Smith. I'm the Deputy Director for Healthcare in Public Health England, which means that I head the team that's embedded in NHS England and also supported the local authorities in their support of CCGs. I think that the PHE role is obvious because public health starts and ends with preventing ill health and protecting people's health, and stewardship of antibiotics and preventing resistance is an important part of what we're trying to do. But my personal role is to make sure that the NHS works together to tackle these things, because working separately is not going to be the answer to this.
Thanks, Kev. Next, Dr. Stuart Bond. Would you like to introduce yourself, Stuart?
Hi everyone, I'm Stuart Bond. I'm a consultant antimicrobial pharmacist and I work at the Yorkshire Hospital's NHS Trust based in Wakefield. I'm also chair of the Yorkshire and Humber Antimicrobial Pharmacy Group, of which Miles is a member as a representative of medical and PHE as well. And my role within the organisation is to be one of the infection experts and also to provide that expertise beyond the walls of the trust as well, so out within Wakefield and North Kirklees CCG, so the local area, and also to try and work at more of a regional level to reduce some of the variation that we see in our guidelines and our practices.
Okay. Next, panel member Jane. Would you like to introduce yourself, Jane?
I'm Jane O'Donnell, Head of Health Protection for the Kirklees Council in Public Health. My role is obviously gaining assurances on behalf of the Director of Public Health on the way forward that the system as a whole is working to help reduce the AMR agenda. I think we, in public health, it's very much an influencing, negotiating role, working very closely with key partners.
Okay, thank you, Jane. And lastly, not least, David.
Hi, morning. My name is David Charlesworth. I work for NHS England and NHS Improvement. That's our current title. My background is working as infection control lead in an acute trust for many years, then joined NHS England, and last year I worked for the National Gram-Negative team doing some quality improvement work, and I've now come back into the north doing some support work for the two new north regions around broad IPC and HCAI, focusing, to be honest, mainly on provider trusts. And my role, NHS England and NHS Improvement's role, I think is, as pretty much as Kev said, it's that umbrella bringing organisations together. I don't believe I have any great expertise that isn't already within the room and within the region. It's about harnessing those to be effective.
Okay. The government published the UK's 2019 to 2024 National Action Plan to tackle AMR in January this year. What are the key messages from that action plan, and what is your, and you can interpret that as Kev Smith or PHE, what is your #1 priority?
Key messages and #1 priority. Key messages, we can't wait any longer. Key messages, this is far more important than people, other than the people in this room think. Key message, we already know what we need to do. We could keep writing these documents every year and the same things would be in them. Is there any way that people could start doing them? I think that's a key message. The #1 priority, I think, is that up to date, quite a lot of the work that's been done has been on elements of the strategy in silos. And a response to the past 5 or 6 years would be, that's made some improvement, but it hasn't made the groundbreaking improvement that we need. And so quite a lot of the strategy is talking about you must work with people near you to work out what they can do and what they're already doing. And the idea then is that we work in a systematic way across the whole, so that each of the elements of the strategy can be done for that population. An approach that says, on this ward we've sorted it, fails because the next ward hasn't sorted it. An approach that says we've sorted it in hospital fails because community hasn't sorted it. The problem of having fantastic GPs and amazing, what we've now got over and over again, brilliant pharmacists in general practice who are doing great work, but the out-of-hours service is run by someone else, and sometimes between 6:30 and 8 o'clock it's somebody else, and then there's a walk-in centre. We've got to work systematically. So
I think one of the things that Kev mentioned that I take away from the strategy is that idea of working together, and I see people around the room who I see regularly from outside of my own organisation, and I had the pleasure of going up to the northeast to sit on a review, I guess, of what the integrated care service, the whole of the northeast, including some of the North Lake district as well. And the areas of the northeast that were doing really well were those ones who were able to demonstrate that they're working across boundaries and bringing into the same room people from the acute trust, domiciliary care, the council, CCG, and actually coming together and having discussions about these things in a way that allowed them to take some practical first steps. And so I think that's the thing that I would take away from the strategy as Kev's mentioned.
From a local authority perspective, would you like to answer the question as best you can?
I agree with both what Kevin and Stuart said about it. It's about shared perspectives, those shared conversations, ensuring that you've got the right people in the room. And sometimes I think it can be hard for things aren't always in your gift. You're not always a commissioner. You're trying to influence some of the commissioners to ensure that AMR, IPC is pivotal, to commissioning arrangements. So at times it can be quite frustrating. I think we've got to probably look at more creative ways of working. I think across our system, particularly across CKW, we've got good working relationships, and we have that too. We have those honest conversations about what we're able to do, what we're able to influence going forward. But also with the changing landscape now, we've got primary care networks coming into the equation. It's how do we start to influence those to see that the AMR is a priority going forward.
Okay, thank you. And finally,
so I think Kevin hit the point. We talk a lot about it's a global message, and none of us would disagree with that. But what does that mean on the shop floor to individual parts of the NHS system and the social care system? And I think there's partly something around how do we stop thinking about NHS and social care and think of it as a punter, as a patient, as a person in the middle of all this, trying to navigate around our increasingly complex system. So my personal view, and that will be supported by E&I, is that I do wonder over the last 5-10 years whether, because we've sorted MRSA and we've sorted C. diff, whether we've lost some of the system focus on infection prevention control, particularly out of hospitals, because they were seen to be hospital predominantly focused organisms. We sorted that so we can relax a bit, and I wonder whether with all the NHS changes since 2013 we've lost that system focus on IPC.
The successes that we've had have been in the short-term wins, and those aren't actually the things that are going to make the long-term difference. So quite a lot of the focus over the 5 years was on things that were going to be achievable, and we were going to be able to say, this is what we can do. And we lost sight of the broader one. So it's exactly the point that's been made about what are we trying to achieve? We're trying to achieve a point where nobody gets into what's it. Well, no, because we've got a separate body of work, which is about the fact that we're not getting to sepsis right. Is it about making sure that patients are not asking for stuff? Well, patients will always ask for stuff. The understanding of the answer might be something that we need to work on, but it's also about empowering clinicians to be able to have that conversation. And the shift that I see in this latter approach compared to the first one is a recognition that this isn't going to be solved in 5 years. I think that if we see this as a culture change over the next 25 years in order to prevent what we know will come if we don't have that culture change, then the change we need to make are incremental, and we have to establish each beachhead as we go. If we're just trying to make an achievement and then make another achievement, we're not going to actually build this into something that's going to make a difference. But it's more complex than this. So it is true that the rates are higher in areas that are more socially deprived, but in areas that are more socially deprived, it's cheaper to build a care home. In areas that it's more socially deprived, the quality of general practice is in general not as good, although that's not always the case. We have some fantastic practices in private areas. It is true that the disease burden, which leads on to being susceptible to disease, is higher in those deprived areas. Doing the research to do the analysis that tells us something in 5 years' time that inequalities is a factor, well, we already know that inequalities is a factor in health. I think that at a local level, what you want to do is you want to look at what are the cohorts where you've got risk. And those cohorts of risk, identifying it as the poor areas isn't necessarily the case. It's about saying it is that we've got problems with our community catheter service, it is that we've got problems with care homes where there's a propensity to call out of hours services for antibiotics. There's the care homes that have got a revolving door with the hospital, the people who are in and they're out and they're in and they're out, and they're the people, they often have a higher risk as well. So I think that you could go down the deprivation route and it would be useful as a research exercise, but in terms of actually making a difference to practice, it's important to understand the cohorts of risk for your population.
From an acute trust point of view, do you notice anything that suggests that the more deprived areas of your community in Wakefield are areas that have more issues with HCAI or antimicrobial resistance? Or, as Kev said, it's actually quite complex. It's not just simply a case of, oh, they come from that postcode and that's more deprived than that postcode, and that explains everything.
I think it gets difficult to drill down below the level of a local authority or a CCG, doesn't it, Kevin? But one thing in the Greater Yorkshire and the Humber is, when you talk about the south and north-south divide, we see evidence of that in Yorkshire and the Humber as well, where the burden of antibiotic use, say, as a measure, is much less in the communities of Airedale, Harrogate, York, than it is in south of Yorkshire, Wakefield, Rotherham, Barnsley, Doncaster. And so that overall burden of use drives a high burden of use, and this is coming from a pharmacy perspective around antibiotic use, but that's one thing that we see in Yorkshire and the Humber is what should our target be in Wakefield versus what should the target be in Harrogate, and is it appropriate that those two be different?
Can I just throw this? I'm going to put this back on you, Debbie, with NHS England and improvement. What is the workforce plan for the next? We can't deliver any of this without a workforce.
Okay, the short answer is I don't know. It's not something I've been involved in. But I can, with my North East and Cumbria hat on, which is where I live and work, I would echo, much less eloquently than Kev, that it's exactly the same issues in Cumbria North East. But I think there are some glimmers. We're talking about a traditional GP and pharmacy and nursing workforce. What that's given us the opportunity to do is to think in different ways of delivering a service. So Stuart's example in Wakefield do we need a microbiologist and a pharmacist? And can we knit a post that does some elements of those roles to provide this service? In general practice, we have more nurse practitioners who we know there's some evidence that they prescribe better because they're less gung-ho and nurses were much better at following guidelines. So there's some evidence maybe we're more compliant with prescribing. So I think there are some glimmers. So I don't think all is lost. I think it doesn't address the underlying issue of we need to knit more GPs and knit more pharmacists, and it needs them to be funded and attracted. But I think we can look at other areas of developing services.
Okay, so there's a real workforce challenge that certainly we need to be mindful of, as you say. In your word was, if you're going to get sick quick, because in 5 years' time, things from you're almost being pessimistic that things will be worse in 5 years.
Oh, you know me, I'm never pessimistic. I think there's realism here. So all of us are working in a system where we know that things are going to hell in a handcart. But the NHS has faced far worse. And actually we can make an improvement in this. The difficulty is that we've got to make sure that we're focused on things that are going to make a long-term difference, not patching up and meeting the latest fashionable target and going along with, oh, well, we'll divert funds to meet that target because then we get 20p from somebody that we wouldn't otherwise get. It's important that we keep the leadership focus on things that are going to make a difference in the long term. And especially, workforce doesn't grow overnight. And quite a lot of the challenges for workforce is, as people are not there, the job gets harder. So the people that are actually doing the work are suffering from the fact that there aren't people coming to help them. So we've got to support the staff we've got, as well as recruit more.
Yeah. And I think certainly one of the messages that I would take away from that mini debate would be we need to think a bit more flexibly about our workforce, consultant mycologists, antimicrobial pharmacists, but that kind of allied health group of individuals, whether it's community pharmacists, nurse practitioners, who are the people that could be part of our stewardship teams going forward to make an impact on AMR, and not simply sort of the traditional role, it's a consultant mycologist or it's an antimicrobial pharmacist. We need to think a little bit more flexibly, because otherwise we're just not going to have the capacity to be able to meet challenges that we're expected to meet within the next 5 years, never mind beyond that. As you said earlier, Kev, this is not just about the next 5 years, it's about the whole future. Okay, can I move us on? There's another question that's been asked here. What strategies are being introduced to reduce the burden of antibiotic usage in animal management? So I'm going to start with the local authorities. What authorities have in actually controlling the use of antimicrobials in veterinary medicine or animal husbandry, etc., etc.
And we work, obviously, public health work very closely with our environmental health colleagues, we work closely with DEFRA, so I think we have those relationships, but they're not going far enough. I don't think we're influencing enough to get out really about the use of antibiotics within the animal industry, really. I think that has to be the focus going forward.
Okay.
There are a couple of, I can answer a few things about this, Miles. There are some challenges around, not very many humans go home and lick their surgical scar. So that's one thing that humans don't do very often. If you've done,
I just sort of add an additional comment on that, and it feels a little bit like global warming, and we obviously had the statements, I think, from Theresa May about signing up the UK to carbon neutral by, I think, 2050, and then the argument comes back, well, it's all very well, the UK being an island and we get carbon neutral, but what about China? What about India? What about Africa? What about North America? And so I think the point was made about the American pork and so on. And we know certainly there's been a lot of resistance detected. I think colistin resistance in Chinese pork, I think, was one of the many reports that we've seen. So surely this is a kind of global strategy that we need to control the use of antimicrobials in food production. But at the end of the day, the population of the world is growing. All of these more populous countries, in some instances, India and China have got 1 billion plus people to feed. Where is all that food going to come from? And it's all very well as saying, well, you don't need to give antimicrobials to these chickens or pigs in the UK. But their argument will be, well, our populations will starve if we don't do this. We need to maximise our food production. So how can we win that argument? It's that trade-off, isn't it? We need to feed our population, but at the same time not kill them with antimicrobial resistant organisms.